Primos and its previous, the same kind of group of drug, the cyclosporin, created a revolution in transplantation about 30 years ago, by which they took care of one of the major issue with transplantation, which is rejection. Because if you put one organ from one person to another, it's going to be rejected. The immune system developed over billions of years to be able to identify a foreign antigen, a foreign body, and reject it. So cancer inhibition and tacrolimus, which is now used widely, is very good in controlling rejection. But it comes with a very heavy cost. And the heavy cost is just as an example, you're putting a kidney in a patient, a new kidney, and you give him tacrolimus, which is nephrotoxic. It's toxic to the kidney. So this is a kind of sounds like an absurd, right? Why are you giving a drug that actually causes damage to the kidney? You're doing that because you don't have choice. So we are here to provide a choice. We want a drug that's going to do as good as job, uh, and not less as a job, like tacrolimus to control rejection, but going to avoid some of the major consequences and costs that patient pay by using tacrolimus. Nephrotoxicity is one of them. Then you have toxic to the islet cell of the pancreas that causing diabetes. You have severe neurological consequences, like brain fog and tremor and insomnia, a problem to sleep, headaches, uh, hypertension, some other probably effect on overall cardiovascular system. All these create patients that are not happy. They're happy that the graft is working, and of course, we need to avoid rejection. But overall, patients are suffering. And I want to alert you to a paper that was just published last month in American Journal of Transplantation, when the American Society of Transplantation surveyed 10,000 patients about these particular issues. What bothers you? And what bothers them is everything I just mentioned. So it's all the tremor and the diabetes and the headaches and the hypertension and overall feeling with the brain fog and feeling like not well. So this is the real issues the patient are complaining about actually. So Tegoprubart, which is a different mechanism of action, we can go into that in a minute if you want, is provides, a different type of drug, totally different, and avoiding all these side effects, as we proved in a phase 2 study we just concluded and presented in a kidney week in Houston in beginning of November. First of all, the difference between calcineurin inhibition medication and tegoprubart is the fact that tacrolimus is a small molecule. It given as a pill and being taken orally, which means that its effect is distributed throughout the body. Every cell in the body who has this calcineurin inhibition, calcineurin play a role in the metabolism is affected. That's why we see all the side effects, because it's effect everywhere in the body. Uh, Tegoprubart is part of a class of medication that are monoclonal antibody. These are very specific antibody that directed to a specific target. It's not affecting everywhere in the body, just affecting a very specific target. Now, what we learn, as I just mentioned earlier, that the immune system over the years developed a lot of pathway by which it can be activated and work against foreign invader or foreign body. So one of them is through the calcineurin molecule, and calcineurin inhibition is one of them. The other part, what we call co-stimulation pathway, which is another pathway by which the immune system is being activated. And CD40 ligand is sitting in the center of this co-stimulation pathway, and by blocking it, we actually blocking the ability of the immune system to launch a full attack on the graft or on the foreign body. There's also difference between CD40 ligand and CD40. CD40 ligand blocking apparently affecting broader pathways in the immune system, in the co-stimulation overall pathway, by blocking other antigen like 11B, for example, which is also part of this attack mechanism of the immune system against graft. So we are working with a very specific, smart, so-called, like a cruise missile, right? Very smart, very specific, that going after core core function of the immune system and neutralize it. So it has an effect on preventing the activation of B cells and T cell and production of antibodies, and all this is leading to its effect as a good immunosuppressive therapy. And because it's so specific, all the side effects that are associated with tacrolimus are not part of what the patient experience or what we see when you're using Tegoprubart. So one of the things we learned over the years that we were able to control rejection pretty well, and usually most of rejection happened in the first year. So controlling the rejection in the first year is of course very important, and tacrolimus doing well, and Tegoprubart, as we show, doing also well. The issue is here, of course, not the first year after transplant. We want patients to continue to enjoy the graft for years to come. And what we learn from that, or what over time, the experience shows that maintaining a kidney function in the first year, 2 years, 3 years, 4 years, 5 years is critical for long-term graft survival. Maintaining of kidney function and avoiding all kind of other complications, mainly cardiovascular issues and diabetes. So by using a CD40 ligand blocker like Tegoprubart and maintaining good kidney function in the first year and after that, we are probably able to improve long-term graft survival and long-term function of the graft and have the patient enjoy the graft for more years to come, because avoiding all the nephrotoxicity and all the other stuff that's causing the graft to be lost earlier than we want. So it's really critical. And what developed in the last 2 or 3 years also is another new kind of concept. It's called the iBox, which the iBox takes and it's a predictive model that based on what you see in the end of first year after transplantation, you can predict graft survival. And the main component there that is really important is the EGFR, is the function of the kidney. And if you keep the function of the kidney at 1 year in the right level, you have a better chance for long-term graft survival. If you are nephrotoxic or causing the kidney function to deteriorate in the first year and continue after that, your long-term graft survival is also going to be jeopardized. So this is really critical. And the iBox is now being discussed with the FDA if it's going to be part of assessment of new immunosuppressive drug. It wasn't approved yet. It was approved in Europe. This gives the emphasize how important is EGFR to maintain it from the day of the transplant forward in order to maximize the survival of the graft. Because of all the issues I just mentioned, our vision, the way we started to develop the Tegoprubart from the phase 1 that I just presented some of the finding in the American Society of Transplant Surgeon conference in Phoenix. From the day one, we said, okay, Tegoprubart is going to replace tacrolimus as the main core immunosuppressive. So our vision, based on everything we did so far and the way we're going now, hopefully to agree with the agency, with the FDA, on moving into the phase 3, is to provide a real alternative to tacrolimus. And my vision is to see in 5 years from now, more and more patients, and hopefully most patients, are being put in Tegoprubart instead of tacrolimus. And by doing that, provide them a drug that has no all the side effects and the safety issues related to tacrolimus, and provide them with a good kidney function and long-term graft function and graft survival. We just finished phase 2, which is a relatively small study with total of about 120 patients, 60 on each arm, tacrolimus versus tegoprubart. By the way, this was the first ever study that tested head-to-head tacrolimus against tegoprubart and a CD40 ligand blocker. So this small study gave us some assurances that tegoprubart working well, that it's safe, at least by the data we have so far on the phase 2, which is a small study. So when we're moving forward in a large phase 3 study, we need to establish really what we call the safety efficacy profile of the drug and make sure that while it's doing its job as immunosuppressive drug and prevent rejection in the right way, it also does not, add or create concern about safety. And the safety mainly, always in transplantation, in any drug, is when you suppress the immune system, you open the door for more infection, and usually viral infection. And we're talking about CMV or EBV or BK in kidney transplantation. So the balance between, preventing rejection and not causing safety concern like infection, viral infection, and others needs to be established and needs to be understood in a very good way in order to be able to use the drug in a safe way with patients. So moving forward to phase 3, what we need to establish in a large study that actually tegoprubart is a good immunosuppressing drug and prevent rejection in a good way and as good as or not less good as tacrolimus, and also have a very accepted safety profile vis-a-vis infection and other issues. And of course, as we already know, avoiding all the side effects of tacrolimus. So this is the way, or that's the way we're going to structure and the question we're going to put up front when we're moving forward to phase 3. And by the end of phase 3, we hope to have established that tegoprubart is effective immunosuppressive drug with a very good safety profile, eliminating all the safety issues of tacrolimus, and provide patients with a chance for long-term and good graft survival and graft function. I'm in the business of transplantation for about 30 years or more. I started as a liver transplant surgeon. As a transplant surgeon, I was actually doing transplantation. So I was very close to family and patients. I understand the way patient and families, the journey that they're going through. It's a unique journey. You're taking, if you think about it, what we did, we achieved the last 50 years, we're able now to take patient with end-stage organ disease, kidney or liver or heart, and replace with a new organ. This is fantastic. This is unbelievable. So it's a very complex process. It has a lot of issues with that. And in the last 30 years, we trying, 40 years to try to learn more and to advance and to move forward. It's time to move forward from tacrolimus. It's a great drug to control rejection. It has a lot of unwarranted side effects, and patients are suffering. Uh, I hear a lot from physician when I talk to physician. It's time to find replacement. We need new drugs. It's a really unmet need, and we need to try to find something new. So I hope that tegoprubart, and of course the other drugs are being developed, and I hope they're going to be successful. But I hope tegoprubart, which we are doing, going to fit into this new era of transplantation, by which we can provide good protection from rejection and avoiding all kind of side effects and maintain good kidney function for long term and provide long term graft survival, and patients can enjoy the organ for a long time. So that's, I hope, going to be the outcome of all that. And for me, it's going to be a very um, uh, satisfactory kind of sense that we are able to really contribute to a significant change in patients journey after transplantation.